joining us on Help Choose Home When Care is Needed, a podcast all about the benefits and value of receiving care in a place that you likely feel most comfortable wherever you call home. I'm your host, Marilee Orsini, and I've been involved in healthcare at home since 1981. Each episode, I'll be talking with a guest who will help us in our quest to educate about healthcare at home. So let's get started on today's episode number 12. This is the second part of a two-part series featuring Arnie Cisneros, who is president of Home Health Strategic Management. Arnie's been in the home care field for over 30 years as a physical therapist and a consultant, and his focus is on quality. Well, you've really been at the forefront of trying to have individualized care plans for patients and not do a one-size-fits-all. How does that fit into our system? Are you teaching that adequately?
Yes. Thank you for noticing that, Marilee. I really appreciate that. When we were in, and I guess I want to make the statement, one of the first care environments that I worked at was home care. But that's more because it kind of fit my personality. I mean, in the early 80s, not that many people were doing home care. I like to be a little unique. And you've seen that kind of evolve over time, that following the patient. That patient that I found in home care and in skilled nursing facilities were the patients that I'd gone to physical therapy school to learn how to treat. So initially, when people would come in, that I would hire other clinicians, whether it's PTs, PT assistants, or OTs, or speech pathologists, they would have nursing home experience, which led them down the other path, which is we're in no hurry to resolve this patient. And I had to retrain them in order to get them to work on our model. One of the things that we might have done in the nursing home is flesh out the evaluation more than normal, and then make sure we track exactly what we do in the care treatment for that patient on a daily basis. So if Arnie treated them on Wednesday and Marilee treated them on Thursday, it would be just like Arnie treated them both days or Marilee treated them both days, because you would know exactly what we did yesterday in the physical therapy element, including the exercises and to the specific repetition number, so you could continue to move the graph upward by continuous care. And we had quite a consistent response from that. Basically, I would tell the clinician that I would be hiring that I'd pay them $2 an hour more than they're asking for once they achieve fluency with this new model. And all of a sudden they were focused on that, and it went well, and then they understood the customization of that patient's care program. So when you take that same concept to home health, I think in home health we have some practice patterns that may or may not support getting value out of the program. So off the top of my head, one of the things we need to do is to flesh out our OASIS admission assessment. And that's a difficult model. We've educated our clinicians, but Medicare still believes, and I think this is indicative of my belief system, is that our discharge OASIS documents, the assessment that we do at discharge, are much more accurate than the admission assessments, and that is because we know the patient. We learn the patient over the care program. And so according to Medicare, we kind of dull down the admission OASIS, create a care plan, and then figure out who the patient is over the next couple of weeks. Now, I know you couldn't say that in the Medicare or the MedPAC offices without somebody saying, well, how much is that costing us? And so what our model is, and when we do this to home health, is we try to flesh out the OASIS. And we've done a lot of studies on the OASIS, and in the case mix questions, which are 26 questions, we have about a national average of about being 70% accurate. So out of the 26 questions, we tend to get about 16 to 18 of them accurate. So that sets us back right from the start. Now stop and think about what that means. The OASIS assessment is supposed to tell you a list of the care items that you're supposed to pay attention to for Medicare, that Medicare wants you to pay attention to get the patient better, and will pay you to pay attention to. And out of those elements, we only capture less than 3/4 of what Medicare wants us to do clinically with the patient, and therefore wants to pay us for. And we're saying, no thanks, we only need 3/4 of the model. And at the same time, we're complaining we're not paid enough. Well, we're not paid enough because we're not getting the case mix questions 98% accurate or better, and then creating a care plan directly from that, directly related to the OASIS, and then making sure we deliver that efficiently. So the first thing is in order to stop handing out a one-size-fits-all home health care mitten, is to measure the digits of the fingers on the patient's hands so we can get them a form-fitting care glove instead of for home health. And that means getting the 26 case mix questions 100% accurate. And that, from our perspective, revolves around three different things. Assuring that the patient or that the provider's clinician, admission clinician, has been instructed on accurately answering those questions and having a guidance manual for those 26 questions in the home during the assessment. It also involves making sure that the patient is taken on a functional walk during the OASIS admission rather than an interview. And then lastly, it takes collaboration with somebody ruling on the patient's clinical performance outside of the visit. So in our model, we assure that all start of care clinicians have the guidance manual to answer those questions. They collaborate with the office in real time, including the patient in their care plan, as Medicare wants us to do. And then they have to do a functional walk, or we can't complete the OASIS. So all of a sudden, we've taken 3 steps that really shrink wrap the accurate clinical profile, now which we can now manage. We want to make sure that a patient with a minimal medication management gets a start of care minimal nursing assignment, and we want to make sure that a patient with a maximal medication decline gets a maximal nursing assignment for start of care. Now, we're not going to play all of those out, but we want to make sure they fit what the patient profile tells us now. That is nearly impossible to do for a frontline clinician. And it's something the frontline clinician has never done in any other Medicare job that they've worked at. So when I talk to you about the ACO models and working across the care continuum, that's what I really run into, is no other provider lets their frontline clinical staff make these decisions than we do in home care. And that's really an element of how we can improve the model, is making sure that we focus on the patient and what the patient's getting out of it, other than the provider or how the clinicians' working habits tend to appear.
And what could we do differently in that initial intake in OASIS as a clinician to try to get 98% of those 26 questions answered correctly? You mentioned the 3 things, but I mean, is there something we can do as an industry that's scalable to teach that, or do we need to pull that somehow out of the process?
That's a great question, Meryl. These are great questions. Thank you for letting me participate in this. The first thing that we need to do is internalize that we have been educating our frontline clinical staff for about 15 years on the OASIS, and that has not worked. So I don't think it's an educational component. You can send them to the classes forever. It just does not seem to be an educational component. How much education are we going to give them before we stop thinking education works? So I think we have to take a look at it differently. When we educate the clinicians on the OASIS answers, we educate them on all the answers. We make no attempt to indicate the importance of the case mix questions. So that's the first step, is to make sure we understand that the case mix questions are very, very important. The second component is to understand that this is difficult for a clinician to do without assistance. Just stop and think this. The hospital version of our admission clinician is the triage nurse in the emergency room. And if the triage nurse makes some mistakes on the intake of a patient that's going to be admitted and sent upstairs, the hospital doesn't live with those mistakes. They correct them, and they make sure they deliver the right care plan. So who are we using to correct our inpatient clinicians' admission mistakes? And the answer to that is, well, we've used scrubbers. And scrubbers don't indicate correctness, they indicate consistency. So if you have a series of case mix questions that identify a patient, let's say on a 1 to 10 scale, they're at a 7 level, and then you incorrectly provide 3 answers that make the patient look at a 3 level, the scrubber scrubs them out at a 5.5 level. So the scrubbers do not do what we need to do. It's talking about each individual clinical question for the 26 questions. And those are difficult questions sometimes. You have to get a patient in a specific position. So when you talk about the frontline clinician on their own, who is not really knowledgeable about the difficulty of this particular question or the nuances in getting it right, and then you provide them with a difficult task in order to identify the answer to this question, you often lose. So we want to put in a scenario that makes it more likely that we would get the quality out of this admission. So what we do is, first of all, we understand that we've educated our clinicians enough. We want to educate them on the 26 questions. Then we want to make sure that they understand the importance of the answers of these 26 questions, because the care plan is going to be derived directly from those questions. And then we make sure that we support them in the home. A, making sure they have the guidance manual. B, making sure that they take a walk. And then C, that they review those 26 questions in front of the patient with a utilization review or a quality assurance provider or employee from the provider in real time. And if there's a problem, then we can sort out that one individual question at a time. That collaboration tends to take 6 to 8 minutes. And one of the things that you'll hear the clinicians say when we train them with this model is, oh, this seems really involved. I don't know if I'm going to like this. And 3 weeks into the new program, they, to a person, say, if we go back to the old way, I'm quitting. And all of a sudden, they are supported in their oasis. They understand the questions they're supposed to do. They have assistance from the office in real time. They aren't arguing with the patient because the office is on with the patient, and the patient understands what their care plan is, and we're doing that all according to Medicare regulations, and they become clinicians again. The nurses become nurses. The therapists become therapists, and they don't become case managers or program production clinicians, which is never what they signed up for when they became clinicians anyway. So to, first of all, understand the problems there, and B, solve the solution for the patient. And we go through different steps of difficulties with the clinician. Sometimes the clinician forgets to call from the home for the first time. Sometimes they don't want to call. Well, we're unconcerned about that. It's not about the clinician. It's about the patient. And then from the data of the care plan that is derived because we have OASIS accuracy, from the data from the OASIS, we create a care plan from that data, just like the minimal data set nurse does in the nursing home. We say, we've got an unsafe patient that's 66 years old. We want to get a physical therapist in here 3 times a week before she falls, suffers a subdural hematoma, gets a craniotomy, and dies, which happens all the time in geriatric care. So we don't need a physical therapist to tell us this is an unsafe patient that's really dangerous. We need a physical therapist to get in there for 3 times a week and make her safe. And that's really the change of the model, which is in home care we're used to asking all our clinicians what to do, and Medicare thinks we know what to do, and how we get our clinicians to do it is on us. And I think the lack of utilization review, which is managing your care program through somebody besides a frontline clinician, is what providers need to internalize that will lead them down the path of failure in this new model. I want to make a comment about that, not related to home care. Before 1984, frontline clinicians ran hospitals. Doctors and nurses decided when the patients were going to go home. And for about 10 years, Medicare had been saying to the frontline clinicians, get them out faster. They don't need to be here so long. But our caring frontline clinicians, our caring nurses, and our caring physicians, they just couldn't help themselves. So they couldn't get anybody out of the hospital with a Medicare designation faster than a national average of 17 days. And then Medicare put in a system called diagnosis-related groupings, or DRGs, which said we're only going to pay you for 7 days for a fractured hip. And all of a sudden, the Medicare had to hire people not manning the positions of frontline clinicians to manage the frontline clinicians. So today, a doctor and a nurse create the notes of how the patient's doing in a home, and a utilization review person, not seeing the patient, reads those notes and manages the doctor's and the nurse's patient. And all of a sudden, 17 becomes 3.8 days. And I think that's really important to understand. Those nurses and those doctors are managing that patient through their documentation. If the doctor charts on a Wednesday that the patient moonwalked down the hall 75 yards, they're going home Thursday morning, period. So I think that that's the model that the home health providers might want to ponder. That's our model, which says let's pull the care control out of the cars of our clinicians and the homes of our patients, back into the agency where we can control it, and then the agencies are able to help their patients or help their clinicians help their patients to successful care outcomes. And the clinician really likes that because, again, that's what they signed up to do, is to get the patient better and not wonder whether I got question 27 right on the case mix answers.
Arnie, just I would love for you to be the person in charge of directing how we're delivering home health in the future. So you see.
I think that's an appropriate position, but I think you and I might be a minority.
You have a lot of the answers, and it's a very complicated system, as you can tell just from listening to you. But it also sounds like there's been wonderful strides made, and we are continuing on this quest for higher quality, lower cost health care. So
I think that's totally correct, and I think that I personally, Marilee, I like the change. Every time the change comes, it's easier to get care to the right people in the right times. I'm a clinician. This is healthcare. I mean, it's like the music industry. You're only as good as your last hit. If you've been doing it for 5 years, it almost probably shouldn't be done anymore. We're a changing industry. We should marry ourselves to change. That's what it's about.
Well, good.
And I think that those are things that if we can internalize that change, and we have the ability at the home care edge. We're the wildcatters of the healthcare industry. Mm-hmm. So we should be able to morph ourselves and change our path easier than anybody else. And I think that's really what we lack. I wish we had more of a national professional identity in which we could do that through, in which we pulled our people forward rather than just tried to protect last year's turf. Well, because I think we really have an opportunity to define healthcare in this world, and I don't think I think home health doing what they need to do in the healthcare world is just a smartphone of the healthcare industry. All of our 16-year-olds have smartphones. We aren't using one in healthcare delivery yet for all practical purposes. I think that's where the future is heading.
Thank you very much, and thank you for your time today and for your insights and for all the energy that you put into the industry and making it better. So it is appreciated.
Thanks for the opportunity to speak with you, Marilee. It's been great.
Thank you so much for listening today. And a special thanks to our sponsors and partners, Access, National Association for Home Care and Hospice, and Core Cubed. You can find more on our website, helpchoosehome.com, and on social media. Join us, won't you, to spread the word and help choose home when care is needed.